Testing 1, 2, 3, 4.
I'd like to introduce our next guest. He's no stranger to you folks. I've known him primarily via telephone calls for the last year. Our next speaker is Dr. Boyd Haley. Dr. Haley got his bachelor's degree from Franklin College, his PhD from Washington State University, and his postdoc from Yale University. He's a preppy. He's professor of medicinal and biochemistry at the University of Kentucky. You know, he's done tremendous research on mercury and its relationship to systemic disease, in particular neurological disease. He's authored 118 118 papers that have appeared in peer-reviewed journals, and he's done over 200 abstracts. And I told him, I said, you know, I like a cigar once in a while, but I take it out of my mouth. I don't know if you understand that. I've had the opportunity to send him multiple cavitational samples and root canals, and he's going to tell you about the results of those. Dr. Haley, would you come up? Put that in a pocket somewhere.
That's a floating. Can you hear me like that, or do I have to use the other one?
This is for the tape. This is for the audience.
Okay.
And this is mobile.
Okay. Okay. I'm all set. Yeah. Is this on? Can you hear me? Is it on? Is it on? Okay, good. Okay. Okay. I'll present this research today, and I'll tell you, I'll try and keep it as simple. There's nothing simple about what I do according to most people, and you'll have to pardon my personality. And I guess the best way to describe someone like myself is this story about a collaboration that probably should occur here today, where you had a dentist, a physician, and a research scientist joined together in a collaboration, and they're working, and they decide to go to lunch. And as they go to lunch, they're walking along this thing, and in Kentucky, where we have lots of floods, something happened, and all of a sudden they saw something that looked like a beer can sticking out of the side of the bank, but as it got close, it looked like an antique. So they all made a rush to grab it. And when they pulled it out, sure enough, it was an antique vase, and a genie popped out of it, and they were all there. And he looked around, and he says, well, I usually give 3 wishes to whoever finds me, standard genie. He says, but since you're all here, I'll give you 1 wish apiece. And of course, the physician, being the most aggressive of the group, says, me first, me first, me first. And he jumps up, and the genie says, okay, what do you want? He said, I want to be on a yacht in Bahamas. I want a safe full of money. I want 6 beautiful women to take care of every need and desire that I have. Poof, he was gone. And then the dentist jumps up next. He said, I'm next, I'm next, I'm next. He didn't say that. She did. She said, I want to be in Tahiti. I got to keep this straight. I want to be in Tahiti on an island. I want 7 handsome Hawaiian-looking men to take care of every need I want. I want all the food. I want nothing but the best of weather and the best tanning place on the beach, and to be taken care of totally. Poof, she was gone. And then he came to the scientist. It was his turn. He says, and now what do you want? He said, I want those 2 back in the lab right after lunch. So the thing I'm trying to tell you is you have to be a little bit bent and maybe permanently damaged to be a scientist. And when you see some of the stuff that we're talking about, and you say, well, what the hell made him think of this? I can't give you an answer. It's just the way your mind works when you approach things like this. But first of all, I'm going to have 2 little overheads here to show you, for those of you that want to stay awake, and you don't have to follow this to follow my research, the rest of the talk, but it will help if you're curious about how we determine this technology, because this isn't something you find in very many laboratories. This is used all over the world, but most of the probes that are made in at the University of Kentucky, and they're shipped. They're used actively in Germany and Japan and several other places. And you can ask the question, what is photophysical labeling? So I'm going to take you back to some very basic biochemistry. This Pac-Man looking character here is an enzyme. We have a body full of them. And the mouth is what they call the active site. That's where the catalytic activity occurs. So if you have a substrate, which I say is S, which could be ATP, GTP, or something that has to be modified, could be glucose, the first thing that happens, you form a reversible complex called the ES complex. And then with time, the catalytic activity of the enzyme releases this as product. This would be something like glucose going to glucose 6-phosphate. What I decided, and for a lot of reasons, the main reasons being for the development of drugs. You know, drug therapy is nothing more than getting a drug that will inhibit a catalytic activity or a binding operation of some natural compound. So you want to make analogs, and you want to see where they bind on a protein, and I don't want to bore you to death with that, but this was a tough thing to do. When I first got out of the Army, as a matter of fact, I should tell you, the last time I was at Carmel was December 26, 1963. I was a soldier here at Fort Ord going through basic training. I had a 3-year paid vacation courtesy of the U.S. Army to a warm place, but it wasn't, it was warmer than I wanted. And all I can tell you is that I came here and had a Christmas dinner with a resident of this town who always brought 3 GIs to his place for Christmas dinner out of the training thing. So I left here and I didn't see a white tablecloth for about 2 years. But and I learned what the comment that, you know, to be shot at and missed means. Okay. But anyway, when I got out of the Army, I was really hot about doing research, and I took science and the chemistry serious. And this is something that I developed in order to determine about these active sites. I would make what we call photoactive analogs of substrates. The idea is you take a substrate, you make it radioactive. You take that radioactive substrate, and then you make it photoactive. By photoactive, I means that when I hit it with a photon of light, it literally explodes and turns into a very reactive compound that will attach itself to the enzyme or the protein that's closest to it. And so this is the photoactive analog of the substrate, and when I make it radioactive, that's this little blue star on it. Now, the idea being that in the absence of light, I can add this to 2 enzymes, a preparation that contains 2, 50, or 100. It makes no difference. You can do this in crude homogenates. And I've just drawn 2 to keep this simple, a mixture of enzymes. The photoactive substrate, because of the nature of enzymes, they only bind their substrate. It will only bind reversibly to this one. We then hit it with a photon or shine light on it, and we get irreversible binding to this enzyme, and this is what we call photo. We use light, affinity. It has to have affinity for the protein, and the radioactive tag makes it labeling. And with this, we can look at the properties of enzymes. And this is shown with what we'll talk about today in this last little graphic, where we have an active enzyme with a smiling face. It looks like a Pac-Man. If we inactivate this by heating it or putting it with a toxin or a denaturant, anything that would kill that enzyme, its active site changes. It turns into a kind of a frowny Pac-Man. And if you mix these 2 with the active substrate that this one would bind, you get binding and you get photolabeling. If it's inactive, there's no binding and there's no photolabeling. Therefore, to understand the material I'm going to talk about, you have to know that exposure to inactivating chemicals reduces photolabeling. That will be mercury in this case, and the toxins that you find in cavitational material and root canals. By adding them in this process here as toxins, we kill the enzyme and we see reduced photolabeling. Now, our analytical technique is to use SDS gels and autoradiograms. And to keep you all on the same line, I'll cover that part up. If we have a mixture of proteins and we want to see how well they're doing, we put in our probe, we hit it with light, just as we talked about before, and then we treat it with a detergent. It's SDS, sodium dodecyl sulfate. It's the active ingredient in Tide. And it takes a protein. Proteins look like a wound-up ball of string, would be a clever description of them. And it stretches them out, and it puts a negative charge all up and down the molecule, so now you can separate it by electrophoretic technique called polyacrylamide gel electrophoresis. So we take these dissolved proteins, and we place them on a gel. Polyacrylamide gel looks like Jell-O out of your mother's or wife's cooking, except it's put in a slab. The front of it looks like this, but sideways, if we look at it sideways, it would look like this. It has water on top, water on the bottom. It's connected by a current. We have a negative pole and a positive pole, and we take these negative proteins, we place them here, and we turn on the current, and they start running down this gel. If we look at the front, it would look like this. We have little slots made in there so we can put multiple bands on at the same time, and we separate them. Then the current, we stain them. The proteins stain blue. We dry this so that we can store it. You can't walk around with a handful of floppy Jell-O, so you dry it on a piece of paper. And we separate the proteins, and they come across as blue bands or blue spots on the gel. And one of them in there will be radioactive. Now, to determine that, we dry this on paper, we put it in a X-ray holder with film, and the film will develop a dark spot, an X-ray film, only where the proteins are photolabeled or where they have radioactivity attached. Now, an example of this, okay, look at this. This won't show up very well, but some of you can probably see that. That's an example of a dry gel. You see there's a paper background. The back of it is a piece of paper. And those are proteins that we've separated. Each one of those blue spots represents a protein of different molecular weight. Can you all see it? That's just all. That's what a dried polyacrylamide gel looks like. And this is an actual experiment. This experiment, and this is the autoradiogram made from that experiment, came out of this holder. We just run through the X-ray machine or develop it, and so we can see which of these proteins are radioactive. Now, with this data, we can be a lot more elegant than that. I have instrumentation that will count the radioactivity. But if you look at this autoradiograph, this is a study, and this is what you're going to be seeing slides of. So if you follow this, then you'll follow the rest of the talk. This is control without it being inhibited, no inhibitor added. And here I took 5, 10, 15, 25, and 50 microliters of a soak that I just put a root canal tooth in and just let it soak in that water for a period of time, pulled it out, and then tested it for toxicity. This is tubulin, creatine kinase, and this is actin and glutamine synthetase in this band. And you can see that this tooth, 5 microliters of 1,000 microliters of an extract of the tooth just setting in water is quite toxic. And by the time we get out here, the toxicity is quite remarkable. We compare this because in some publications, and you're a dentist, so you know that hydrogen sulfide is made by periodontal disease bacteria. It's a cause of bad breath, etc. Hydrogen sulfide is a very toxic gas. So we make a 2 millimolar solution of hydrogen sulfide, and we compare its toxicity. And you can see we've gone 5, 10, 15, again increasing the concentration of hydrogen sulfide in micromolar amounts. And you can see this is toxic also, but the root canal tooth is quite a bit more toxic. We're using the hydrogen sulfide to set up the standards, so I can say this tooth is more toxic than this tooth, and more toxic than hydrogen sulfide or less toxic than hydrogen sulfide. And so this is the nature of the talk you're going to hear now. And what I'm going to do is also go back and tell you how I got into this mess. Could I have the slides?
Move the mic up here.
Okay, thank you. Sorry if I don't talk loud enough. There's one thing I think should be made clear. When we're talking about mercury, mercury is not mercury is not mercury. Mercury vapor as it comes off of dental amalgams is the most toxic and dangerous form of mercury that exists. Basically, because it does not have to be translocated anywhere. Mercury in the HGO charge is lipid soluble. It's hydrophobic. It would rather be in oil than in water. It's a gas. Being uncharged and hydrophobic means that it will go into the mucosal membrane, straight into the brain, past the blood-brain barrier. There is nothing in the biological system that it's not permeable to. So you don't have to transport it through the bloodstream or any other factor. It will go into the fatty layers, the tissue layers, mucosal layers, and go wherever it wants. It is like taking a bomb in a suitcase and sending somebody off with it. It's going off. It's totally, at all not dangerous until it explodes. The explosion is when it's converted to Hg2+. This is toxic. Now, if you drink mercury in the Hg2+ form, it won't get into your brain very likely. Very little of it will, unless there's something to help carry it across the blood-brain barrier. The vapor goes across the blood-brain barrier very well. This form will mostly end up in the liver and the kidney, etc. But this is the toxic form. Once it's in there, it reacts with sulfhydryl groups and it is locked into place. Of course, methyl mercury is a different story. This is from a paper by Murray Vimy and Fritz Lorscheider. But okay. I didn't know I could talk so fast. But so the problem is when someone says how much mercury, they say, well, they put this much mercury in a system and they showed no neurological effects. If you're good at putting it into drinking water, it doesn't work. Now, we have a paper coming out in neurotoxicology where we got more mercury in 2 weeks at 4 hours a day of exposing rats to mercury vapor than I could get in feeding rats mercury in their drinking water at high concentration for 7 months. The bottom line is that's how you get mercury in the brain, is a vapor, not the cation. And if you understand, when our ancestors, our great ancestors, migrated across the face of the earth with our knuckles dragging the ground, we ate bad food and we drank bad water, but we didn't breathe mercury vapor. We have no protection against keeping mercury vapor out of our brain and the following bad effects that it would have. Can I change this now?
Yeah, thanks.
Okay. This is the transport system, and, and this is the axonal transport. It's something that has been brought up earlier, but what I want to talk to you about, this represents some of the proteins we're going to be talking about, and it's essential for the survival of neurons. And what we find that there's a protein called beta-tubulin, and it forms a structure somewhat like this. It's the railroad track of the cells. It requires GTP to bind, and it has a sulfhydryl in its GTP binding site. And that means it's very susceptible to mercury toxicity. On this thing sits things called little molecular motors. They're kinesins, kinases, they're ATP binding proteins. They use ATP, they bind neurotransmitters, and they carry them at different directions on this railroad track, this tubulin railroad track, and dump them at the end. You have to have those for a neuron to survive or for you to have proper neuronal function. And that's a graphic. So we'll be talking about a couple of these proteins. If we do an electron micrograph, these white lines here show how tubulin is interdispersed throughout a cell. It's the railroad tracks, and you could look at that, and you have to have this working properly, almost all of it, and there is a lot of tubulin. In brain, tubulin is the major protein. And so this is the transport system or the rail system of a single micro, I think it's a fibroblast cell. So we can tell that those little tubules that you're seeing are quite extensive in most cell types. Now, for a cartoon presentation of this, we can look at how microtubules are made. There's a material called GTP, and you have tubulin. It's a heterodimer. It's got an alpha and a beta subunit. GTP binds, and it polymerizes. And in polymerization, we form the railroad track. So those are the rails. This is the railroad track, and it looks like a hollow core. And we have to have this interaction for us to go on. When I talk to you about the probes I made, this is a zero GTP. This is what I do for a living. I make these phosphates radioactive, and in the upper corner, you see that N3. That's an azide. Lead azide, copper azide, you can't ship through the mail because it blows up if you hit it. This molecule explodes if you hit it with a photon of light. And this is shown by that top slide. If you have the azide setting happily on a protein and you shine light on it, it literally blows up, giving off nitrogen gas, and it creates a molecule called a nitrine, which has got 6 electrons in the outer shell. You all know, remember the octet rule in chemistry? It wants to react, and it has a half-life of 10 to the minus 10th seconds. So if it's in water and not bound, it reacts with water. If it's on the protein, it immediately labels and binds to the protein as one of the most reactive chemical intermediates known. This is the process if you look at it. If the substrate molecule is setting in the active site, these R groups are the amino acid residues. If you hit it with light, you see that it will photoinsert with one of the residues that's in the process of binding it. And that's how we work this system. The process that we talk about this is how we do it with GTP. We take a brain homogenate, we add the photoprobe that's radioactive. This 32 here means this is 32 phosphate, radioactive phosphate. We incubate it for 20 seconds. We shine light on it for a little bit, and then we process it like I told you about for the gels. This is a gel, and this is what got me into this mess. I work on Alzheimer's disease. I primarily, my research goals today, other than structural biochemistry on purified enzymes, is to try and find the differences between a disease state and a normal state. In other words, I take brains from normal patients, samples, and then samples from Alzheimer's patients, or MS, etc. And if there's a disease state, one thing you always find out is that the nucleotide binding proteins will change. In every disease state, they do not have the same nucleotide binding proteins. And this is the process. So we had here on this particular one 5 human control brains and a series of brains that were AD. Now what you have to understand about AD is that it's diagnosed wrong somewhere between 10 and 30% of the time. So not all these ADs will be ADs. And we do this before we get the absolute diagnosis, which can only happen after you're dead, and they section your brain and look for easy for me to say, neurofibrillary tangles and plaques. But you can see the gel staining looks fairly much the same. When we do the autoradiogram from this, if you look at the Alzheimer's, some of them have no photolabeling at all. Essentially, all of them have reduced photolabeling down at least 60 to 70%, indicating that their tubulin is aberrant. Alzheimer's disease brain is the only brain that does this. You can have it from multiple infarct dementia, Pick's disease, any other neurological disease. This is the hallmark of Alzheimer's disease. And we do screens like this on a regular basis. Another one is shown in this slide. The first 4 on the left are control, and the rest of these are Alzheimer's. The one right here, I think this is the one, that looks like it labeled turned out to be a diffuse Lewy body disease. He wasn't Alzheimer's at all. So this is how we screen it. Now, it was looking for the cause of this. If you understand Alzheimer's disease, it is not the major description of Alzheimer's disease, the major form of late onset, is not inherited. I mean, it is not a genetic, you may have a genetic predisposition, but you do not inherit it. You can have 2 identical twins, one will get AD and one will not. What the likelihood is that you have the genetic predisposition, but you have to have the toxic insult to push you over the hill. And so we were looking for the toxicant that might cause this type of aberration, because this held up extremely well. Over 80% of the clinically described Alzheimer's disease brains show greatly reduced or abolished tubulin photolabeling. This is a slide that the American Dental Association hates the most, I've been told. And to make a long story short, because I'm not going to show you all the data how we proved this, what we found, and we screened a lot of heavy metals, and we found that the mercury, and only mercury, and mercury at submicromolar levels, prechelated with EDTA or prechelated with glutamate, which is a natural occurring amino acid that's 10 millimolar in the brain, will cause this effect. And if you look at this slide, it's talking about adding mercury at micromolar, 0.8, 2.3, 6.1, the 2 ADs. And if you look up here where beta tubulin is, you can see it's not here no matter what we do. This is a control, and this is a control. And when we add 0.8 micromolar, it drops off 60%. When we add 2.3 micromolar, it's essentially totally gone. So, and bottom line is, mercury affects the same proteins at very low concentrations that we see affected in Alzheimer's disease. It doesn't mean that mercury is the cause of Alzheimer's disease. It does mean that if you are prone to that disease, this would exacerbate your symptoms. You should not, be exposed to mercury. No one should be exposed to mercury for any reason, in my opinion. But this does show that it does exacerbate, and it could be the cause. But this does not prove, nor do we say it is the total cause. It is an oxidant that affects the same proteins that are affected in AD brain or in AD tissue. Now, the major thing that people want to say, they said, well, maybe they're not making tubulin. There's a thing called Western blotting. You use antibodies, and you can determine the level of tubulin. What this slide shows, and I'll not belabor it, is that you can see this band all the way across is the same. This is just a protein, an immunostain for tubulin presence. And even in AD, the protein is there. It's just not working. It looks like a protein that's there and bound by a toxin. Furthermore, we found a major glitch in this, and that's that the tubulin in Alzheimer's disease is not in the soluble fraction. It's in the pellet fraction. It's abnormally precipitated in the pellet, whereas in control, it's almost all in the soluble fraction. That's what this slide shows, but I don't want to waste time going through it. You'll just have to take my word for it. If you'd like to see this afterwards, well, we'll go over it. But this is another immunoblot. Now, this is the latest bit of research has talked about the ApoE protein. A lot of you have heard of that, haven't you? It's the protein that tells whether you're genetically predisposed to getting Alzheimer's disease or not. The difference in the ApoE2 versus E3 versus E4. When I first read that, I immediately looked up the structure of those enzymes. If you have E4, your chances of getting Alzheimer's disease are quite high. If you have E3, they're considerably less. And you have 2 copies, one from your mom, one from your dad. If you have 2 copies of this, you're very likely to get Alzheimer's disease before you're 60. Conversely, if you have 2 copies of ApoE2, which there are very few people that do, you're not likely to get Alzheimer's disease until you die, of real old age, like 90 plus. This one here puts you intermediate. And the difference, and the total chemical difference between these 3 things is the fact that you're going from cysteines to a cysteine plus an arginine to 2 arginines. Arginines do not bind mercury, don't interact with it. Cysteines do. I think these are protective. I think this one doesn't protect you at all from oxidizing metals such as mercury. Other metals could be involved also. And the data is shown here. If you have 2 4s, you know, the age of onset is much less than 70 years. If you have a 3 and a 4, it's somewhere between 70 and 80. If you have 3 and 3, the average age would be 80 to 90. If you have a 2 and a 4, it's 80 to 90. If you have a 2 and a 3, it's much, much greater than 90. And if you have 2 2s, you're not likely to get AD at any time within a normal living span. This is other people's work. This is from Roses, from Johns Hopkins University. He's the one who, his laboratory is the one that discovered this. They don't talk about mercury, though, which irritates the blazes out of me. Okay, now we're going to talk about the use of these compounds in a diagnostic test. And what I'm going to tell you now is how we've developed a diagnostic test using this approach for amyotrophic lateral sclerosis, Lou Gehrig's disease, and multiple sclerosis. And this is the probe we use. We change it. This is a ZOATP. It's another high-energy nucleotide. And this is what we call a two-dimensional gel. Wherever you see a blue spot, like here, or here, here, and here, that's where we've separated this protein out by isoelectric focusing and then separate it going down with the different molecular weight markers. And you'll see this kind of data on these slides. This is a stained two-dimensional gel. This is the molecular weight in thousands, kilodaltons, of these molecular weight markers that are stained blue. And using this process, we did 15 control cerebral spinal fluids from people from the University of Kentucky Hospital. And you can see that the proteins are spread out all over the paper. And where I've drawn this arrow, we see this band is right here. Please remember that spot corresponding to 14,000 or just above 14,000 kilodaltons molecular weight. We compare this now to 6 out of 6 ALS patients, and that protein is missing. This has turned out to it's held up extremely well in our laboratory, and what it requires is 200 microliters of cerebral spinal fluid. So this diagnostic test is there. All these other proteins were the same proteins that you saw in the control. So there's just this one protein that appears to be missing. And I can't say right now. I mean, because I'm not supposed to say what it is, for obvious reasons. I mean, not obvious scientifically, but for other people. Now, the next set, using a slightly different set of conditions, we're going to compare controls to multiple sclerosis patients. And if we look here where I have protein B, we see this area is very clean. Where B prime is, there's a light haze there, but nothing that one can discern. And right here, where I have A, this mark of A, it's very clean, and there's protein 1 and 2, which will reappear, as well as some of the other proteins. When we take the MS patients and we do it, we see that this protein at B shows up, and B prime, the only place we've ever seen this has been in an MS patient. Protein A, while we do see it in a few AD patients, we don't ever see it in controls, people that don't have neurological diseases. We haven't seen it in many other neurological diseases. It's not there in ALS, if you remember. So it does indicate that we have this as a successful approach to detect and diagnose certain diseases. And the reason I presented this is, one, it'll tie in, especially the missing protein in ALS, to what we're going to show later. The fact that certain toxins can knock out proteins at photolabel, knock out all of them, but just take out 1 or 2. And I want you to show you the power of this technology with regard to looking at disease states. Now, this is a polyacrylamide gel of brain proteins treated with extracted tooth toxins and or cavitational materials. And what we've done here, these are the brain homogenates. We've added the toxin material that's been extracted from the tooth, and we have over here the control. This is hemoglobin, or pardon me, albumin coming from the toxic, the dirty tooth, and this is where we've added creatine kinase. You can see an extra batch there. Now, I want to tell you how we make these toxins. It's real difficult. The toxins, or you take the tooth, to make the toxins, we take the extracted tooth, it's sent to us, it's dirty, it's got blood on it. Blood does not inhibit photoaffinity labeling. Actually, I can measure the proteins, the enzymes in blood. So blood is not an inhibitor. You take the tooth and you drop it in a mill of distilled water. You take it out, You drop it in the second milliliter water. You can do this sequentially several times. You can incubate it for 10 minutes or 20 minutes or an hour in that water. Then we put, when we get through, we put a cap on that, we store it in the freezer, and when we're ready, we take out lambda aliquots. A milliliter is 1,000 lambdas, or 1,000 microliters. And we see inhibition at maybe somewhere between 1 to 10 microliters with some teeth will totally kill all the enzymes in the brain. And we can do it on a third extraction. Most of the stuff that you're seeing here today is done on a third extraction for the main reason. I don't like using the first extraction because someone can argue with me and say, well, that's because of periodontal disease, something from the outside of the tooth. So we wash it off and we save it, and we do that twice, and then we take the third extract for our studies. So that we can absolutely look at somebody and say, no, it's coming out of the inside of the tooth. And we'll show you some experiments where we damage the tooth and show that it comes out even faster. I mean by damaging, scraping off the periodontal ligament or scratching. Yes?
Are you vibrating it in any way?
No. No. The tooth just sits in there.
And you can tell that it's from the inside that it actually doesn't
Yes.
come in?
Well, listen to the talking. You can tell me whether you agree with me or not. But anyway, this is where we use this to make an autoradiogram. And our controls are on the end there, and in a control where we added extra creatine kinase, because creatine kinase seems to be the enzyme that's most sensitive to these toxins. And then in this particular set, you can see that the controls would be out here on the end where we look at creatine kinase. This level, we put in creatine kinase right here. You don't see it too well. And as we go across, this is not showing up so well. This protein is disappearing, knocking out, and I'll show you more dramatic effects that go on. And I brought this up front for one reason. Here, we see this increasing. I don't know what that is. I don't know what that is, but in certain teeth, it will increase as we go up a bit higher with the toxins. If we do a screen of these teeth, and these are teeth that have been sent to me by other people. If you go across and you say, here's your control where I've added nothing, you can see the level. If you compare this to this, to this, here's one that's extremely toxic. Here's one that's not toxic so much to this protein, but quite a bit more toxic to tubulin. This is the same way. When we get to this one, here again we have one that's quite toxic there. And you have to compare these to this control. And the level, this tooth right here, does not appear to be that toxic at all. So we do find these effects. Now, these two teeth are out of the same patient. And if you look, this one labels quite nicely. This one is dramatically down. If we go to these teeth, 5-8, these are all from the same person at different locations. This tooth is dramatically different. I haven't seen a tooth that is so toxic that knocks out tubulin totally, doesn't affect creatine kinase. The next tooth over here from the same patient dramatically reduces the flow labeling of these two. Tooth 8 raises that one a bit and takes out creatine kinase. We have better, these are the first shots. The later autoradiograms we have, you'll see, are much clearer. This is just another set of screens, and in the space of time, I'll not go through a lot of those, but if you look at the top band very clearly, comparing it to the control, you can see there are some that are not affected, some of them, like this one, that are totally abolished, 4.5, they're totally abolished, and many of these are control teeth. The bottom line is, without going through and describing each one of these people, etc., some of these teeth should not have inhibited very much because they were not from people, they were not root canal teeth, they were teeth that we collected as controls. This is another screen. These three here are from the same patient. This person was ill. You can see that one tooth was fine. One tooth is extremely toxic. The second tooth only inhibited up there. From the same person. All three looks like a control tooth. One that totally wipes it out. One that only takes out the top band. That tells me
Root canal teeth. Are they all root canal teeth?
the only ones that we have found that inhibit the photolabeling are dead teeth, avital teeth, or teeth that have root canals. Teeth that were pulled that are extracted for other reasons are not that. Not all root canal teeth were extremely toxic. Some root canal, but all the toxic teeth were root canal teeth or avital teeth.
Were the teeth that were controlled, did they have fillings in them?
Some did, some did not. We got the whole plethora of them. Those with the mercury-filled teeth didn't seem to be any more toxic than the non-mercury-filled teeth in this time frame. I mean, that's not very long for mercury to come out. Now, the problem, and some of you look at that, those were 1-point concentrations. I mean, I have to go through and I have to take, 50 teeth, and I have to take 50 microliters or 20 microliters. I have to pick an amount and test them all the same. Some of them, it doesn't work very well. So here's what I'm talking about. Here's a comparison of 2 teeth, and we've done a lot of these, and I don't want to bore you with bringing up 50 of these things. Tooth A, which was quite toxic. Tooth B, which wasn't so toxic. On the concentration where I first measured them, this tooth is toxic. It takes out this protein very readily. You can see it's going down to here. But it's still, if we compare it now, so we have an ml of an extract of tooth A, an ml of extract of tooth B. Here's our control. This is creatine kinase. As we go across, we wipe this out somewhere between 5 and 15 microliters of a 1,000 microliter extract. The tooth over here, and I use this as an example, it's, you just don't see much toxicity until you get out around 50, and that's down about 50% versus this one right here. Now, autoradiograms are deceptive. We don't look at that and make that decision. We count it on an AMBUS 4000 auto imager. It tells us how much radioactivity is in each one of these bands. It's a computer-driven thing, and I can take my cursor and draw a square around this or a circle around this, and it'll tell me how many counts are in this. And it'll compare it to each one of these, and you can see the data drop as we go through. So the problem is, and this may sound like bad news to you, but this is great news. No one can say it's my technique. If you do 2 teeth, some teeth are more toxic. They've been in your mouth longer. The person's sicker. They may have a different bacteria in the tooth. They're producing a different type of toxin, and they'll give you this effect. I would tell you that every time the most toxic teeth we've found have been from MS patients and 1 Parkinson's disease. Those teeth are the most toxic. Now, I don't mean to imply that that says they cause the disease, but either the disease exacerbates and allows the bacteria to grow better, or the bacteria and the toxin coming from that root canal is helping the disease progress along. This is all Chris Husser's work, and they're all his patients. And I've got the thing here if you want to, I don't know what the names of them, but they're all on here. What we have here is a comparison of cavitational material and devitalized teeth. The controls are on the 2 outside lanes. So let's talk about the devitalized teeth. That's what he called them. I assumed that was dead teeth without root canals. Yeah. And if you look at them, this one's the least toxic, but it kills creatine kinase. This guy is second least toxic. It kills creatine kinase, wipes out actin and glutamine synthetase. They run together, so I can't separate them. This tooth over here is extremely toxic. This protein's wiped out in all of them. This protein's present in some of them. This one's wiped out in 2 of the 3 and quite low in the 3rd. These are devitalized teeth. Over here, I don't know what number 7 had, but I wouldn't want it. But if you just look, I mean, you can look at this. Here's what the control. This is albumin that's in the blood, because when you dig these out, you get a little blood. So this is serum albumin. Down here at the bottom is hemoglobin. But you can see these proteins. So this number 1 wasn't quite so bad. Here's one that loses creatine kinase in this protein, but kind of keeps this one. Here's one that lowers this one, keeps this one, and goes in and out. Here's one that doesn't bother that one. We've lost the one in the center and the one on top, and you can look at them. These 2 are wiping out actin. And again, those are considerably different. So what this tells us is that we're dealing with more than 1 toxin. We're definitely dealing with more than 1 toxin coming out of these teeth. Because some of them will wipe out tubulin quicker, and some will take out creatine kinase quicker. And so this is not a simple, straightforward process. What is simple and straightforward is that cavitations are all very toxic. They're very toxic. I mean, there's something in there that kills enzymes. And these enzymes are critical enzymes. Creatine kinase, cells can't live without creatine kinase. Tubulin, you can't maintain cell shape, function, and you sure can't do neuronal transport without tubulin. So the material is quite toxic. This is a gel, and this is done for reasons that are more complex than what I want to take the time to explain here. But what we did is where we say pellet and supernatant, we took control brain from humans, spun it down to make a solid pellet. All the membranes and the hard material, the material that's not soluble, comes down and ends up in the pellet fraction. The soluble proteins, those that are soluble, are kept in the soup. We separated those two things, and then we treated them. This is our control here in the center with 0 treatment. This one over here, we increased the microliters of toxin that we extracted out to 20 microliters of 1,000 microliter extract. Over here, we increased the concentration of hydrogen sulfide, a very toxic gas material, and it's produced by periodontal disease bacteria. And we made an autoradiograph to show the function of this. This full labeling was done with the Zito GTP, which is specific for tubulin. And if we look at the root canal, the toxin, this is our control, the soup, the pellet. Tubulin is in the soup. And as we increase the concentration of toxin, when we got over here to 10 microliters, tubulin was totally wiped out. If you compare this then to hydrogen sulfide, 100 micromolar, 200, 400, 800, so the toxin in root canal teeth is not hydrogen sulfide. And the reason you can tell that, if I opened up the solution of hydrogen sulfide, 3 millimolar is what we used as our standard, in this place here, in about 3 seconds you would all be heading for the door wanting out of here. It smells very bad. Some people like it or it can't smell. But this material that we extracted from the root canal had no smell. Nothing that you couldn't smell unless you put it up to your nose very close. If you did that, you got a light sulfur type of odor, but it wasn't hydrogen sulfide. So whatever's in root canals is a lot more toxic than hydrogen sulfide. Now, if you're not a chemist, but the one thing you know about hydrogen sulfide, it dissolves collagen material. If you have collagen, which is just a protein, it's a connective tissue protein, if you add hydrogen sulfide to it, it'll break it up into little bits. It reacts with it, chemically dissolves collagen and bone and connective tissue. So when you say, well, why does periodontal disease, why does my gum line disappear? Well, hydrogen sulfide is a very reactive material, and it will actually cause proteins to lyse in half, just like a proteolytic enzyme. And so that's probably the process that causes some of the loss of of tissue in periodontal disease. And I think the bacteria that are in these root canals, are similar to those that are in periodontal disease, except they're locked inside and they're more anaerobic and they're contained and they produce a more putrid thing. So when we plot this data, you can't hardly see this, it's not that bright, but if we look at this on the MS, this is a root canal from an MS patient, by the way. It took tubulin down like a rocket. It was taking the two enzymes in the 45 kilodalton, which is glutamine synthetase and actin, down, whereas the hydrogen sulfide, at the concentrations we looked, were slightly elevating it. And that is the reason I think, and our tests have shown this, hydrogen sulfide at very, very low concentration actually enhances photolabeling. I think it behaves as a reducing reagent. So the initial thing is it takes it up a little bit, and then it drops it off dramatically. So it depends on the concentration of hydrogen sulfide in the toxic tooth with regard to the effect you'll see on the photolabeling. Oh, okay. Here, this experiment was done early before we really had it refined, but it still shows the point. What we're going to do is we're going to talk about comparing several teeth, and each one of them has a line under it. We take the first extract, and with the first extract, you see the excess albumin that's coming off of the tooth from blood, from the serum. That's in every third lane. You'll see it's high, like here. So we did that soak, and we're going to test it for toxicity. And in the third one, we scraped the periodontal ligament off of the tooth. And we did a soak with the periodontal ligament to test the toxicity of that. And in the third one is we took the tooth that had the periodontal ligament scraped off of it, and we soaked it for a third time. And we compared the toxicity of those three preparations on the enzymes that we're discussing. Okay? So this next autoradiogram was made from this. Now, back up one other thing. What we found is that, and the argument people come up with, if I'm using brain homogenate, human brain homogenate, and I run out of George Mining's brain, so I have to go, to, I don't know, Chris's brain, okay? I mean, they may behave differently. They may have different levels of protective agents. He may have a lot of ApoE2 because he's not demented, and look, he's doing great, he's smart, and he's old, and no sign of Alzheimer's, and Chris, we're wondering about him. So what we decided is that we would make a package of 5 pure enzymes that would separate out on the gel, and we would test them and add them to this tissue, and they do separate out, and this is one of our first attempts at this: adenylate kinase, creatine kinase, phosphoglucokinase, and phosphoglucomutase, and we're checking the effect on these purified enzymes. We'll talk more about that in a few minutes. But on this extract, here's the first extract. You can see it's kind of from control. It's toxic. We didn't let it sit very long. The ligament also contains some toxin. It reduced it from here to here. And the second extract did it just as well. The labeling up here is on the albumin, and then it's in each one of these. The third one, this is hemoglobin that comes off. It photolabels very nicely. ATP binds at the 2,3-bisphosphoglycerate site that binds on hemoglobin to reverse oxygen binding. And you can see this first one, though, this is toxic. But the ligament doesn't contain too much toxin. It's down a bit, but not too bad. The second one, after we scrape the ligament off, becomes toxic, but not quite as toxic as the first one. What I think happens here is that there are some of these bacteria and some of these toxins are on the outside. This is the only one that did that, though. The rest of them, if you look at them, as you go across and you do the extracts, the ligament and some of the other things can be just as toxic. Here's one, another one that's quite toxic. Ligament wasn't quite as toxic. Second extract, was up in that region. The second one here, we can see that the toxicity still exists because you have to compare this to this, this to this, and you see that the toxicity is still coming out after we've washed off everything we could get off from the outside. Now, here's how we develop that process. Each of these 3 is a pure enzyme, which we have treated quite differently. 1, 2, and 3 of phosphoglucomutase, pyruvate kinase, phosphoglycerate kinase, creatine kinase, adenylate kinase, and acidic fibroblast growth factor, which is found in the thing. What we've done with these is treat these with root canal toxin and hydrogen sulfide. This would be this one is treated with root canal toxin. This was treated with hydrogen sulfide. You can see that it does not destroy the protein. In an entire homogenate, I can't tell that. But when I separate them out on a pure gel, I can say the process of these toxins is not that they're chewing the protein up like a protease. So they're not destroying the structure. The proteins are there. And if we look at this on the autoradiogram, this is phosphoglucomutase with nothing added, with the toxin, with the hydrogen sulfide, pyruvate kinase with nothing, with the toxin, with hydrogen sulfide. Again, nothing, toxin, hydrogen sulfide, nothing, toxin, hydrogen sulfide, nothing, toxin, hydrogen sulfide. This one, my technician made a mistake. Nothing, toxin, and hydrogen sulfide. And those concentrations were added, predetermined to give us about the same amount of inhibition. It doesn't mean that hydrogen sulfide is more toxic than this material because we didn't add very much of the root canal toxin. So this is a technique that works. What we're doing now is that I'm trying to come up with a technique that if you send me a tooth, I can say this is a class A, B, C, or D toxin. The center is going to be hydrogen sulfide. So I can tell you whether this tooth is more toxic for creatine kinase, adenylate kinase, or tubulin, whatever other enzymes I might end up adding. And the way we do this, these are our pure enzymes. They make nice little bands, and we add microliters of the toxin. We have our control over here again, and then we increase concentration of hydrogen sulfide. And we do an autoradiogram, and you can tell there is no change on the proteins on this side versus this side. So we're dealing with a true chemical toxin. And if we make an autoradiogram from that same thing, here's our tooth. Again, this is 1,000 milliliter extract, or 1,000 microliter extract. This is 5. Look at that. 5 microliters. I mean, that's, I don't know how many of you know what a microliter is, but it's damn little. But look what it did to the enzymes in here. I mean, this is a dramatic inhibition at the first 5, and you can see it wipes them out. And again, if we go to hydrogen sulfide, you see a similar effect. It's definitely a toxic material. It shouldn't surprise anybody, but it's not nearly as toxic as this in the level that you would think would be important. And if someone is talking about growth and inhibition of growth, this band right here is acidic fibroblast growth factor. It's required for the promotion of growth of neuronal cells as well as other cells. And it's wiped out at the very lowest concentration. You can see it quite readily here with hydrogen sulfide all the way out to here. So that's the kind of technology we're working on at this time. Now, to show that we're not faking this data, just setting up to make it look good, this is a tooth, another comparison where we're going from toxin, and you can see the enzymes are listed on the right as what they're identified as. And again, this is done exactly the same way. We go 2 to 50 lambdas or microliters, and again, we increase the concentration in hydrogen sulfide in millimolar, or micromolar it should be. And you can see that this tooth, when we had 2 microliters, this has really abolished this one, had no effect on this all the way across. It barely touched that top protein. So this tooth has a different toxin than the prior tooth. And the hydrogen sulfide behave the same way. You don't have to go up real high, but you finally take out everything on a rather equal basis. So, you know, you can't see all this at one time. You have to sit and look at these, you know, 5 of them on a frame at one time. But the toxins from these root canals are different. Some of them want to take out creatine kinase first, others take out tubulin. And I think as we expand the bank of enzymes we look at, we'll see that maybe there are more. But we can categorize them at this time. This is another one. It's done the same way, except I want to point out, sometimes when you extract from a toxin, there will be a protein material come out. And you can see as this increases, this increase corresponds to us increasing the concentration or the number of microliters of this protein, of this toxic material. So this protein is coming off the tooth somehow or coming out of the tooth. I don't know what it is. Here is our hydrogen sulfide, and you see it doesn't exist. And the curious thing is, this protein photolabels with toxin present. At the same time, this protein is going down. This protein's gone from here down to here. And the hydrogen sulfide behaves the same way it always does. And we see very little effect, except in AFGF. You can see it's going down slowly. It doesn't show up very clearly on this particular slide, but it did go down. And so there are some teeth, and if we look at that tooth, it's not nearly as toxic as the other teeth. So I'm not gilding the lily, just saying all root canals are toxic. And here's another example of a tooth. It's toxic. If you look at this band over to here, compare this spot to this spot, this spot to this spot, it's definitely toxic. But it's not as toxic as the prior teeth we looked at. And here's again, hydrogen sulfide is our internal standard. We look at it, and it behaves the same in all the gels that we've done it on. So we can compare them, you know, on the same process. Now, you'll all be happy to hear that's all I have, except to discuss this a bit more. Yeah.
How long were the teeth extracted before you did this?
He asked how long the teeth were extracted. I want to give some acknowledgments. Number one, you know, I first heard this when I gave a talk to DAMS about mercury toxicity, and I was on the program with Dr. George Mining, and I sat there and listened to him, and I thought, I can't believe this guy, because if I do, I'm going to be scared to death. And I didn't think he was right. I really didn't. I just thought this has got to be something that's wrong. I don't. I asked him. I went up to a few members. I talked to him. He says, "Oh, there's a book called The Price of Root Canals, and Western Price has done this." And I said, "But you can't tell me that this guy killed 60 rabbits in a row, did all this stuff, and no one ever proved him wrong. I mean, this is just too damned important to ignore, isn't it? Wouldn't you think?" Yeah. But they did, yeah. And make a long story short, you guys, I don't have to tell you that story. You all know it better than I do. And then Hal Huggins heard about my mercury research and made numerous phone calls. And you got to do root canals. I said, all right, send me to your damn teeth. We'll do it, and we'll shut this guy up, and he'll leave me alone. I mean, he really he can be persistent. It's one of his attributes, I guess. We did too, and I was shocked. I did this thinking that I'd seen nothing. I really did. I mean, nobody's more shocked about this than me. This is the most toxic material I've ever seen that exists in the body. But and then I've talked to Dr. Husser and Dr. Wurzbach from Colorado. So I have had teeth from 5 different dentists. Dr. Medford, I can't remember all their names, and I'll leave somebody out, and I don't mean to. Anyone, as a matter of fact, I've even had individual people send me root canal teeth that are toxic. They say, I'm sick, I'm having this damn thing out, and they send it, and I've checked it, and you can tell that it'll be somewhere in the level of toxicity if it's a root canal. And I would point out, not all root canals that I've tested could I absolutely say are toxic. You know, there's about 20-25% of them that are extremely toxic. No one, if you took this to a physician and you said, if you had a piece of tissue in your body that put off toxin at this level, at this time frame, what would you do? He'd say, I'd cut it out. It's like a gangrene toe. You'd get rid of it. There's a lot in between, and it spans all the way up to, you know, some being not, I can't even tell you they're toxic. I could not look somebody down and say, I know this tooth is toxic. In my opinion, that's reflective of the fact that this technique finds certain toxins extremely well. It may not find other toxins so well, other types of toxins. So, George?
Price identified 20 different organisms in these teeth.
Mm-hmm.
It's easy to see two extracted teeth from two different individuals might be different in the amount of toxins.
Mm-hmm.
When you have two teeth from the same patient, most people would believe they would be the same. However,
they're not.
what a lot of people don't realize is that if you had 3 root canal filled teeth, you could have 3 different organisms.
Mm-hmm. Yes.
In that mouth, so you could have different diseases caused as well.
And I think that establishes technique. I mean, if you know, you saw the data on the ones, and if you look at the autoradiograms, I mean, this is a lot more clear. And I don't mind if anybody picks it up. If I look at this in my hands, it's a lot more clear than what it shows up here. And you can see the drops. You know, anytime you put something on a film and show it through 30 feet. But the bottom line is, we have several cases where people have sent us several teeth from the same person, and some of them will show no toxicity, and others will totally wipe it out. So, the teeth are individual.
Well,
Yeah.
You don't have a time differential either. You don't know when one root canal was
No.
done, or how long
Yeah.
it was in the mouth, or whatever. Right?
And I didn't finish answering questions. Some of these teeth that Hal Huggins sent me, he told me they were in his freezer for, 4 or 5 years or more. Some were fresh. It doesn't make any difference. I mean, this is a chemical toxin. It's very stable. We've done a lot more studies than this. You can't kill it by heating it. I mean, you can make a toxic extract, and you can let it set out on a bench top, keep it sealed. You can use it for a week or a month. I mean, it's there later. I mean, this one tooth is one of our standards. I'm real big on standards, and I'm very careful. There's one tooth in there that we've got 3 extracts held. They're all toxic, and we just use it as our standard. If I want to make a point, like I'm going to do this next to hydrogen cyanide, or cyanide toxicity and other things, you can use that tooth as your standard as you go down. It's been around for a long time. So this is something like hydrogen sulfide or methyl mercaptan. Some of these things are so toxic that there's not anything that's been reported before, I don't think. I mean, that one that knocks it out at 2 microliters, if someone gave me that or a vial of millimolar mercury and said, take your choice, you got to drink one or I'll shoot you, I'll drink the mercury.
Have you done formaldehyde studies at all?
No, I haven't done formaldehyde, but I've worked with formaldehyde, in cross-linking studies, and it's not this toxic. No. No. Yes? I can't hear you. I'd say about 25% of them, going out to 100 microliters, didn't show. I wouldn't say they didn't test non-toxic. I would be stretching it for me to say I know there's toxin in there, because you can have a 10 or 20%. Almost all of them showed it was down a bit, but you might get that with a lot of different tests.
You know the
So,
medical history of the people that were non-toxic, the background?
nothing. So other people do. I don't. I just do. Yes. He asked you, did I know the medical history? I can tell you that the most toxic teeth, because I call up and I say, I want to know what this is, because I'm worried about, I don't want anything transmittable in my laboratory. MS gives the most toxic teeth, and then Parkinson's disease have been the next. Yes, let's go right here, and then I'll come that way, all right? Yes.
Well, again, in 100% of its analysis, stiffness or bacteria. I wanted to know if you found that. It sounds like maybe you haven't. And number 2, do you have a profile for cancer patients?
To answer the last question, no, I have no profiles for any patients, and we're not, I don't know what, yeah.
Well, you said here's an MS person.
Yes, I haven't,
Haven't had the opportunity.
haven't had any from cancer that I know of.
Oh.
And I would say that as far as what's in there as far as bacteria, this test doesn't show there's bacteria. It shows something in there producing a toxin. I would assume it's a microorganism of some sort, a bacteria or yeast or
Well, there's
maybe.
some, controversy, because what I'm hearing from you is that some root canals look absolutely fine, and then I'm hearing from the Europeans, and they say,
No,
it's 100%
I'm saying,
stiffness
yeah.
more.
But you know, if I go test pond water for cyanide for toxicity, and, you know, and that's what my test is designed for, and I find it. If I don't find it, that means there's no cyanide in there. It doesn't mean there isn't DDT or something like that. So what we're seeing here, this test is very specific for toxins that interact with sulfhydryl reagents, because these enzymes are basically sulfhydryl dependent, and so we can pick those up at very low levels. But there may be other toxins in there that my system doesn't measure. So I'm not saying, I'm not giving root canals a clean birth. I'm a person that deals only in facts. 25% of them I cannot say are toxic. That doesn't mean they're not. My technique did not see that at that level. Let's go here and then you.
Do you have any idea of whether the level of toxicity is based on the actual material that was inside the tooth, or whether, as earlier in one of the lectures, the apical area sucks up toxins from a sick body?
Okay.
Do you have any idea?
Yes, I do.
Which?
Well, I may not know which is which, because I think if you have a tooth that's down in a cavitation or near a cavitation, it's going to be toxic on the outside and a good chance toxic on the inside. One of these people on here was my daughter, suffering from trigeminal neuralgia and chronic fatigue, diagnosed by a physician in Pennsylvania, not me. She was taller than I am and weighed less than 100 pounds when I took her. I thought she was going to die. She had a front root canal, and I was quite interested in that root canal. And to tell you the truth, removal of the root canal and cutting out the material properly, at least I think it was done properly, and because she's doing fantastic. You know, it's like a miracle, and it's hard. You know, that's something that I don't want to bring in because it puts an emotional attachment to your research. I can sit down and detach from that, but I can tell you that I had that tooth, and that was my tooth. I knew what I could do with it. I cut the tooth in half, soaked it, cut it in half. When you cut it in half, you could take the they call it one of your probes, your dental probes. You could grab the gutta perch or whatever that thing is, and you can move it up and down like a worm in an apple. And when you did that, it would blow little bubbles out the bottom of the tooth. And when you took the top of the tooth, the crown, and and the rest of the tooth, and you soaked it, they both had toxins in them. So but I think that the toxin, you know, in that particular case, it can be anywhere. I mean, you guys understand this situation better than I do. Yes.
Are you aware of that some dentists do root canals prophylactically? But what I'm saying, some of those teeth problems that you tested, the 20%, did not have a chance to have the bacteria introduced.
Oh, yeah, I know that. Yeah.
Are you aware of that? That a lot of root canals are done prophylactically.
I'm not. According to the dentist I talk to, they all are. I mean, the one who likes doing these. But I mean, you may be right. I mean, there may not be any bacteria at this time in those teeth. Yes.
Maybe some of those are the ones that don't show the toxins.
I would definitely say there's some that were done better, wouldn't you? Or they haven't been around as long. They haven't been in as long. So I don't know. There was somebody back there. Yeah.
I just was wondering if you would take this hideous poisonous N2, which is still used, which contains arsenic and mercury, and we know about synergies of poisons. What would you get if you would take it as a positive control?
Arsenic?
It contains arsenic and mercury. It's all inside,
Okay.
which you place.
Well,
root filling and
yeah.
filling.
Okay. Well, I mean.
How would you do these?
Well, I know the toxicity of arsenic alone, and I don't know I mean, I'd have to predict that they would be very toxic. But if you stop and think for a minute, periodontal disease bacteria that are anaerobic have to have a different electron acceptor than what bacteria have when they're aerobic. We breathe oxygen, and that oxygen as our electron acceptor and making energy for us is converted to water, H2O. When you take air away, a bacteria does the same thing, by the way. Most bacterial electron transport systems take O2 to H2O, half O2 to H2O. When you don't have air, they have to have another electron acceptor. You die because you suffocate if you don't have air, but they live, they adapt, and they get other electronic, and one of those is sulfur. And that means you can make HS2, hydrogen sulfide. That's their electron acceptor. That's the reason you make it. There's no oxygen in a periodontal disease that produces malodorous breath and things like hydrogen sulfide. There can be other electron acceptors. You could end up with RSH or RSSSR, compounds that are very complex and very toxic and very reactive. The thing you have to think about right now, and this was something that came up in one of the other lectures, I think by Dr. Boku, talked about putting that gauze in the root canal area and pulling it out, and it had 20,000 parts per million. Was that you? Yeah, it was yours. Donder did that. Of mercury. Well, if you think about the fact you have a root canal or you have a cavitation that's loaded with bacteria that are producing hydrogen sulfide and hydrogen sulfide type molecules, at the same time you have about 5 dental amalgams putting out mercury, where do you think that mercury is going to go? It can go out the bottom of the tooth, ground tooth, but it's going to collect where there's a lot of sulfur. And that's the reason you're probably seeing a lot of the material in there that's doing this. Now, we're doing a lot of things to show what can inhibit the activity of these compounds, what chemical things might do it. So I'm not surprised. I think you can make, I mean, if I get this done, I promise you, if I find that most toxic in toxin, I'm going to call it ADA toxin. Because you have... Yes, I'm sorry. Yes.
Wait, have you done any work finding out about the toxicity of the calcium compounds, specifically the calcium oxide that's being used to avoid
Biocalex?
Yeah.
He asked about it. We've done, I think, two or three, I don't want to say it, but at least 2 or 3 teeth with Biocalex, and I haven't seen them but to be toxic. That doesn't mean, that's only 2, you know, and I've seen a lot without Biocalex that aren't toxic either. So for whatever that's worth, that's not me approving Biocalex, but the 2 that I looked at were not toxic. Just 2 of them. I've only done 2. Yes?
How do you recommend to transport the tooth to you?
I recommend you don't until I get ready. We're trying to get this up. This is expensive experiments. You know, I have to, and if you talk to anybody who does science, you get a gel done. One gel is $500. And I have to take care of the radioactivity, the P32, and I have to pay people. I mean, you don't hire people off the streets to do this kind of research. The guy that does this has a PhD. And we've done a lot of teeth. I'm going to try and write and get support. I've tried to get it from Procter & Gamble and from NIH. Good luck, huh? But right now, I did get my NIH grant, which was put on abeyance for a while because I think of my mercury toxicity work, but it was refunded. And so I have 3 years that I can bleed off and do this because it's pretty expensive research. I think but per tooth it's not too bad. But we have to have it organized. What I've done now has been a shotgun. This is preliminary data. Number 1, I had friends that were going to be sued or taken to board action for removing root canals or taking out cavitations. And I knew they were right. I mean, especially with my experience and talking to some of them, they just were not people that did things like that just to make money. So I did a lot of work here, and what you really need is you need a physician involved, you need a dentist involved, and you need a research scientist. And I will keep them all in the lab if it's me. Okay. Chris?
Maybe the American Endodontic Society would fund some of your research.
Are you taking bets on that?
Jerry, if those of us that send biopsies to Jerry, Jerry, why don't you mention the studies you've done with the root canals? Most of the time, I don't care how good a root canal is done, there's always necrotic material in it. Maybe less than 20% come back completely filled tooth.
I think it's time. Do you think it's time also, Jerry?
I see a lot of, it's sort of like, for want of a better term, a demi-moon of calcified necrotic debris. I think it's left over from when they're scraping the canal. Louder, I never see any inflammatory cells. I never see any hemorrhage in there. All I see is this dead calcified tissue. It's chemically dissolved. It doesn't look as if it's still good dentin. I'm wondering if that material itself is producing some of the toxins instead of microorganisms.
Sure. I mean, it'd be like gangrenous tissue. And the only reason you would think that is that you know, if it were just gangrenous, then the same toxins would be there all the time. That's the reason I think that some of them are bacteria, but definitely, you know, tissue that's just breaking down can produce a certain amount of toxins. But if it were, then all the teeth would be the same type of toxicity, and that's not the case. And I would point out, you know, you're not biochemists. Some of you are cell biologists. If you go back and look at your book and say, what would happen if I had a toxin that wiped out creatine kinase that quickly, the cell would be dead. Your immune system can't get near this stuff. I mean, this would kill those cells. I mean, nothing would live through that. And over here.
And that's my question. Can you kind of help us equate how toxic these materials are with something that might be familiar to all of us?
I'm working on that now because I thought hydrogen sulfide was familiar to all the people that were dentists. And that's the reason I picked that. But I've been told, well, no, we want to see cyanide and now arsenic, and we can do that real easy. And
everybody knows what hydrogen sulfide is. That's rotten eggs.
Yeah, that's rotten eggs. But if you breathe too much rotten eggs, you'll die. I mean, it's hot toxic. It'll kill you at 700 parts per million. Yes.
Out of curiosity, how much funding do you think you need to do your work? Get you post NIH, but how much funding do
to
start your studies the way you want to do it? I mean, what are you asking for right now to do this work?
if I were going to propose this project, I would ask something around 80,000 a year for 3 years. I mean, and with help of, and then see, that's assuming I can get a physician and a dentist and some group of dentists to work with me on it. If they start charging your salary, and now I'm not taking any of my salary out of that either. I'm well paid. So, I mean, that's what it would cost to pay the postdocs, get the supplies, the equipment, and set up and do that. But in this, right now, I don't know if you've noticed, but that, we started out just looking in brain tissue, and we thought that would get us in trouble. So we got this bank of purified enzymes, and every week we screen 2 more enzymes to say, can we get, you know, like 20 on a gel, so we can really define this a lot better. Yes.
I guess what are the ultimate complications here? What are these toxins? How are they affecting the adenylate, kinase, and creatine kinase? What are they doing to the system?
Okay.
Knocking out.
They're knocking out a they're knocking out a cysteine. Acidic fibroblast growth factor. I did studies. Acidic fibroblast growth factor was being used by Merck, Sharp, and Dohm, or tested as to put in salves to heal bed wounds or bed sores. It's a growth factor. It's a healing factor. I did the 3-dimensional structures. This is what I do for a living when I don't play with mercury and tooth toxins. And in a 3-dimensional structure where the nucleotide binds, right in the center of that binding site is a sulfur, a cysteine. And so when mercury binds there, it wipes it out, and so do these toxins. So I think that this is these compounds are sulfhydryl reactive, the ones that I'm measuring. Same thing with creatine kinase. That we published that in biochemistry. The active site has a very reactive cysteine, which is a sulfur group. And creatine kinase is very sensitive to hydrogen sulfide and mercury. And so I think that's what we're looking at. What these compounds are, I don't know. I can tell you this. They don't have UV absorbance. They're not proteins, and you can't heat denature them. Not at normal heat. I mean, not like you can't boil them and kill them. They're very stable. They're chemicals. Yes?
You did some cavitation work too. Cavitation, did you do some research on the cavitation, contents of cavitation?
Just the ones that Chris sent, and they're all toxic. Matter of fact, and it's hard to make a comment about them because when people take those out, and I've got them from Chris and Hal Huggins and a couple other people, you know, the volumes aren't the same. A tooth is a tooth, you know, it's all confined. But cavitational material, some of you guys are real neat and you give me a little amount, which I really like. Some of you think I need 5 mLs. I don't. But I mean, so, you know, you can't tell the volume of the cavitation. So I can't tell how much toxin's in that compartment. But I haven't seen a cavitational material. None of them have been sent to me that haven't been toxic. Which you would think, or the tooth or the place would heal, right? Yes.
If this material is sent to you and it's been placed in formaldehyde, does that disturb the effect of it?
Can't do that. Formaldehyde's a toxin itself. I mean, that would kill everything. I mean, it has to be just right. Simplest thing to do is put it in a vial, the tooth dry, just drop it in there, leave the blood on it. I'll take care of that. I don't want anybody else touching it. If it's a cavitational material, you know, take it out with something that doesn't have any toxic material, no procaine if you can avoid it or stuff like that, no formaldehyde, just freeze it. I like to have them both frozen until they get to me, and because that just, you know, it takes care of an argument. I actually think you could carry the tooth around in your pocket for a while and then give it to me and I could find toxin on it. Yes?
The Germans maintain that protein degradation products from the dead were called bioether were captive, and that they were highly neurotoxic. I mean, would that lend an increase to the work that you're doing in this area?
I would.
You haven't identified the specific chemical toxins,
No.
but
I would, if that's their assessment, unless they can show me mass spec data, I can't say they're absolutely right, but it would fit in with this type of thing. Thioethers are much more toxic than hydrogen sulfide. Dimethyl sulfate, if you want to read it up, just get the PDR or the book and look up dimethyl sulfate. It's one of the possible toxins made, and it's extremely toxic. So I would, my data supports them. Matter of fact, it supports everything Dr. Issel has published. I mean, that's what surprises the hell out of me. You know, dentistry needs its butt kicked. I mean, both he and Dr. Price, you know, were the books I read, and I read this. I'm an active reader. I don't talk about things. I wouldn't be up here at all if I hadn't read Price's work and Dr. Issel's work. And I look at that and I say, how can you not give major attention to this in the medical circles? It's just too important. Yes. Yes.
what effect does protein have on the bioethers, or what do we have?
Procaine have one? I don't know. I don't know. Thank you.
Can we save the other question for tomorrow for the session? Is that okay? Okay with you, boys?
Yeah, well, I have to leave. Yeah, I have to leave early.
You're not going to be here tomorrow?
I'll be here in the morning for just a little bit. I mean, I have to catch a plane at 1.
Okay, no, then we get you in. Yeah.
Okay. Right. Okay. Thank you all for listening.
Wait a minute. Can I make a few comments?
Here's your.
Let me at least introduce. This is George Meining, who wrote the book on the root canals that most of us got woken up by. And he's been a real pioneer and a hero for me. So here's George.
Thank you. I'm not sure all of you realize that Price found that the root canals that were there for longer periods, the bacteria became more virile and the toxins became more toxic. Now, Joseph Issel has 3 books, and one of those that is in Russian. Bob, where are you? Printed it. It's available. Chapter 13 of that book is available back on the table back there. And in that, Issel talks about many of these things. But one of them was that he also investigated the toxins in the root canals and in the cavitation areas. He found that the chemical was closely related to the same chemicals that the Germans used to make mustard gas and gas Americans during World War I. And that when people had that chemical in them and had cancer, it was very difficult to ever cure them if they didn't get rid of it.
Are you picking on us again?
And furthermore, he found that some of the cancers were caused by that chemical. And I'd like you to make a comment about that.
Maybe you don't have under
I was just following orders.
You know, cancer. The thing that we know about most oncogenes or proteins that cause cancers are that they're mutations and they're modified. And so I would say that anytime you have a vast exposure to cells, with chemicals that could react, as well as these compounds react with proteins, they would also react with nucleic acids. I mean, they're nucleophiles. They would react with anything. So the possibility of these things inducing cancer would be fine. And I would also say that, yes?
I never thought of thinking for myself, Colin. Now I'm an adult and things may be.
Oh. At any rate, I would say the Dr. Issel talked about the effect on the immune system. When you have this type of toxicity and these toxins going out and modifying so many different proteins, your immune system is going to be totally overwhelmed by the fact it's going to see a lot of proteins that look foreign to it because it has this thioether or the adduct or the R group that comes along with this chemical reactivity attached to it. And also bleeding this kind of toxic material into your bloodstream would definitely play hell with your white cells. And red
I'm
cells.
glad you mentioned that. People who are getting along well with root canals will say, do you think I really ought to have this tooth out? And we have to kind of leave that up to them, but I do remind them that the bacteria that are being released from those teeth night and day, continually are being engulfed by the immune system. Now, how long is it going to take for that immune system to poop out and they no longer do this, or they get an accident or a case of the flu, and now they will develop a degenerative disease from it. So they have to know those things in order to make the choice. You're usually not the one that makes the choice whether you take it out or not. They're the one, and you got to be aware of that. Thank you very much.
Anyway, this was George, for those who haven't seen him yet. I think we cut George short of his applause. I'm sure he, I don't know.
Thank you. right now we're being slightly swamped with them, and what I want to do is work out a protocol and then mail it to people that want to have this done. If you keep those and save them, I'm sure at some time. Because see, yes, the problem, the tube, you just take it out and put it in on a test tube, plastic or glass, and just freeze it. And the cavitational material, if you can get it in a a like a half ml of water or something like that or less, the lower volume the better, and freeze it and send it to us. But it costs so much money, and there's so many people who want to do it, and I just don't have enough money for my grants. None of them are for this. This is all stuff I've stolen from my other grants to keep this going. So, but I mean, I definitely want to, well, I hope so. I'm trying to get funding, and some people say it's very promising, but I don't know yet. Yeah, those people, I mean, that's pretty, yeah.
And now you know why you got it.
Yeah, God was on my side. That happened. Yeah. She had a nickel post, I didn't say that, and because she fractured it too. It had a root canal and a nickel post put in to hold the camera on. And it looks sketchy on anybody can look at that and say that tube was not doing it. And the change in her has been dramatic. I mean,
Even though he doesn't look that old, he's worked with Carmel for many years. He's also one of the best training guys in the world. And one of the best neurotherapists that I know. He lives up the road from me in Vancouver. He's a great skier too. And a very creative mind. Always has been looking along with me like for the last 8 years for the solution. And working out together.
That's where I got it.
Yeah.
Because
So, why don't you stand up until you kind of get going and think about it, just kind of breathe and everything.
I come from
I want to
Mexico.
apologize
My
to
professor,
George.
Dr. Schneider, who's come from Germany, and she has a report for the methylsulfito and the toxin of the root canal. And because I agree with you because I read that report, but I remember is that the methylsulfito you said is more toxic, but she has already that report for that methylsulfito. And I can send to you that report if you want.
Sure. I mean, I haven't heard of that.
Yeah, because the hydrogen sulfide hydroxino, I have two that report, but I have one for that methylsulfito toxin from the pesticide.
Okay. No, I'd like that. Yeah.
I'm basically, I have to it's not fair for me to talk about intraosseous neurotherapy.
I hope I made them understand that.
Background on why I do intraosseous neurotherapy.
Yeah,
What
I mean, I can't.
I'm a dentist, but my main focus is my practice. I'm a chronic illness dentist.
Yeah. I mean,
Chronic illness. I have a practice.
I think if this comes down, what I'm trying to do is find somebody or some company, because this is too much for the person to fund. And if I can get funding,
Let me
go
for a
through
while.
and look
He'll
at
be
these
back.
things, then I'm going to go
Basically,
after
we have a
it.
practice which, and now have.
Oh, I know. I mean, I'd rather take it from you. You're the one who set the samples and investigation with everybody. Some of these people, they put it out into the, they put it in a plastic bag and it would all be
So
poured
we
inside the plastic
approach pain
bag.
from a multi-modality approach. And one of the most powerful procedures I have in my practice is called intraosseous neurotherapy. Why did we call it intraosseous neurotherapy? Because my observations were, when I did the procedure, I got an autonomic response. So, till now, a lot of my colleagues call it the stabident. We don't like to call it stabident. It's intraosseous neurotherapy.
Oh my goodness, thank you.
Now, we have a purpose, why we do it, and now we have certain protocols as we are developing. We have people here like Doug, Dietrich, Chris, everybody is adding on this technology. It came to be as an accident. The first one I did was basically to save teeth that are hot after the crown preparation. And lo and behold, after I did a few, I couldn't believe how many teeth I was saving from root canals. And the first procedure was since I do a lot of homotoxicology, I use a lot of heel products. I used 1% lidocaine, a little bit of lymphomyosate, a little bit of Traumeel, and I injected it right next to the root of the tooth. And most of the teeth calmed down. The ones that they didn't, I repeated the procedure next week, and I would say I have over 90% success rate. I have certain people here that utilize it. You can ask them for verifications. Now, let's go back to the dental component and why it's so important in chronic pain management. If you look at this picture only, we are really dealing with the central nervous system, the autonomic nervous system, and the peripheral nervous system. Remember that. We're dealing with those three nervous systems, which neuroanatomists like to separate them, but I'd like to combine them together because they are extremely interlinked. One of the best part of this seminar was when Chris was quickly flicking over those incredible papers that I've been reading too on distribution of the trigeminal nerve. The trigeminal nerve has connections to the basal ganglia, to the midbrain, to the diencephalon, and also the interconnections of the trigeminal and the autonomic nervous system should be well understood by dentists who are treating pain patients. Could we flip the slides, please? Now, I will go on and describe, is this a slide projector? Basically, I use a stabident as a vehicle to deliver the remedies. And people who don't know about the stabident, I have the address for the company, and if you look at this phone number, they'll gladly send you a videotape and the materials, and it's very easy for a dentist to learn how to use it. I'll go over it very quickly because it's late, and whoever wants to know more about the other components of my pain practice, I will quickly go over and show you some incredible experiments that were done in Japan on beagle dogs to prove to you how important is dentistry in chronic pain management. Basically, the kit arrives without the remedies, and that the last object there, that's a drill, which is 27 gauge as a needle. And the remedies we introduce are endless. This is the drill that goes in your slow handpiece. This is for the dentists in the crowd. And basically, the needle is also 27 gauge. These are techniques I use in my practice, how I combine the remedies. Doug Phillips uses the the needle technique that you use. The tuberculin needle, right? The tuberculin needle, but which works very well. I find I work better with my basic dental syringe, so after I use my anesthetic, I add the remedies via this 10 cc syringe where I add my remedies, including sonum remedies, heel remedies, whatever else you want to use, the MPS. This is a technique I use to fill up the carpules and combine my remedies. Also, as I mentioned before, you could use the tuberculin syringe, which will work as fine, but I find this technique much easier. Basically, you freeze the area with you put some topical anesthetic, and you put a couple drops of local anesthetic there, wait a bit. And this is a technique where you go between the roots, you make sure you respect the periodontal space, and you very gently, slowly, you drill a little hole in there, and you approach with your needle. I prefer to bend the needle in the posterior areas, and gently push it all the way in, as you see in this picture here, and you deliver remedies. That's it. It's very simple. Now, beware of autonomic responses, and before you do this technique, warn your patients that they might have autonomic responses. What are they? They might feel faint, sweaty hands, palpitations, actually tingling. Some of them cry. They have some of them have bliss attacks. Actually, I've seen all range of autonomic. So before you do the procedure, warn them nicely and gently. As a matter of fact, I tell them if we're going to get any of these reactions, it's good news. That means we have a problem here. Now, I took this technique and went to the wisdom tooth site for cavitations. And my first one, because we knew from our charts related to the heart, this patient, a friend of mine, had atrial fib. And I injected it with lidocaine only. He had pain in his chest, but afterwards the fibrillation stopped. Since then, we have only done 2 cases with the electrocardiogram, and the atrial fib literally changed on the electrocardiogram. Because when I was there at the oral surgeon's office, the anesthetists were literally laughing at what I was suggesting. It worked. Now, when you are attempting that procedure, please make sure you warn the patient, because they will be very scared when you do that procedure and they have any cardiac problems. Now, the other reason I use it in the area, when you drill the hole and you inject, if it feels like completely empty, that means you have a huge cavitation site. Now, let's switch back to dentists. When I drill a hole to calm down a tooth and big red blood comes out, I say, good news. Actually, I'm opening and draining the area. Just that procedure probably will help the tooth. So when that happens, don't get overzealous. I've been doing this procedure for 3 years now, 3.5 years. Just put very little remedies. As you know, in remedies, you don't need to put much, less than 1 cc. Okay? So those are the pearls. I can give you many other pearls as they come to me. As you guys, when you ask me questions, I'll be able to give you more pearls. Should I ask? Yes. Whatever I can get to. What's the easiest area? All you need is one area, and it just flows in. Okay? Yeah, very good point. I've also done a lot of the upper teeth, actually, from the palatal side. That's a good pearl. Don't be scared from the palatal side. Yeah. Couldn't hear him. I could barely hear him.
Hausen is one of our top cardiologists, and he says when you convert a patient from atrial fib to regular heartbeat, which is what we're planning on doing with Adarana, and that's what happens usually when you inject the cavitation site that most commonly is responsible for arrhythmia in the heart, even ventricular arrhythmia, heard, the stabident procedure. So when you tend to convert a patient's irregular heartbeat to a normal heartbeat with this procedure, by injecting a wisdom tooth site, you're suspecting that's what it's going to do. And he says we're putting the patient at risk of getting embolism at the time, creating a stroke or pulmonary embolism at the time. And so he suggests that we put the patient for 1 week before the procedure is planned on vitamin E. Maybe?
Thank you. We're learning. Yeah.
Repeat your recipe for the hot teeth again.
I use Traumeel and lymphomyosode. Lymphomyosode is for drainage, and Traumeel is basically anti-inflammatory. Yeah. That's right. Am I what? Yeah, it's an injectable Traumeel.
No, my point is if you're breaking your glass
Yeah, that question has come up. No, I'm not.
I don't know if you do.
No, I don't do it that way, but I have had no trouble.
It's been around since 40 years, and nobody's ever gone up to toxicity. It seems to be okay, depending on how you break it. Use a hammer. But they break pretty clean.
Have you ever looked under the microscope at residual from a ampule?
Yeah,
Can we speak up a little louder? We can't hear you here.
Okay, the problem, yes, when you use the glass vials of the cheap vials of homeopathics, there may be some glass fragments in the solution that you draw up. There's been a couple of studies, people looked at it, and they feel that those glass particles are small enough so they actually dissolve in the body, the silicates, aluminum, whatever it is, and don't lastingly remain in the place where you inject them in to dissolve.
Actually, I would say I'm, without intention, I'm filtering them because I put them back in the dental syringe, goes through the rubber and back up on a 27 gauge. So maybe that's a precaution I didn't know I was, but I don't have any problem. Because I inject a lot of different parts of the body. I mean, I inject most of the days, all day. Yes. Well, we have other dentists here that have some ideas about it. Yes, I don't do cavitations all the time. As a matter of fact, I have an oral surgeon that does them for me now. So certain patients that we don't want to do cavitations, we've observed, and they feel fine. Well, it's not long enough to, I have not done studies. I'm a clinician. I have to earn a living. I don't have a grant to do all these, but eventually that will happen. But what I like about this procedure versus a surgical procedure, if we can manage to revitalize the area, I think we have the matrix already. If you saw the jawbone on the slides by Jerry Boku and these people, if we are able to detox the area and revitalize it, it'll beat surgery. If. Yes.
I had the experience of growing bone back in a patient, actually my wife, who had a pretty good sized cavitation. And we, same technique, same periapical machine, same settings, grew a lot of bone back in, just doing buccal injections, not even stabident, and doing Santa remedies, Notakil, Traumeel, Procaine in the buccal membrane, and also utilizing anthroposophical remedies, silicia, meteoric iron, and other remedies, and trigeminal nerve and so on, in the buccal membrane. And I've done that with a lot of hot teeth, scores of hot teeth. Now, I don't know what they are. Is it an infection, inflammation? I don't know, but I shoot them a couple times and they go away.
Well, I had great
dentistry without a license.
I've had great clinical results that I'm not going to sit here and brag about them. You can come to my office and I show you literally hundreds of cases that we have bone changes on the x-ray, all right? Not hundreds on the x-rays, hundreds that we've done, but several we could see good changes and good response. But I don't have a scientific study as should be scientifically done. I'm a clinician. One day someone else is going to do a scientific study, they're welcome. But the biggest help I have in my practice with this technique is trigeminal neuralgia, which we'll talk about. It's a magic for trigeminal neuralgia.
How do you decide between protein and marketing?
I use Procaine. and lidocaine, basically, and quite simple. I just basically use procaine.
I've had the opportunity to surgery some patients that have been treated prior to coming up to me with Sonams and stabidents, and their bone is much healthier. It still comes back from the path from Jerry as being pathologic, but not too bad. Smaller ones you can get away with that.
Chris, is this a pre-treatment that you're saying before
Yeah,
you
the patients have come out that had Sonams and stabidents. I think they had stabidents, but they've had Sonam treatments. And other things like I was talking about. And the bone is better.
As we can all tell, this is the beginning of a huge research project. We're just starting. It started by accident. We're getting good results, and we'll see what happens. But I'll share with you a lot of clinical results, especially trigeminal neuralgia.
Ara, have you taken this to a step where you might use the procedure as a lavage of the cavitation by putting an exit portal and running through a larger amount and then stop and then refill it with your final Santa remedies?
Well, if you've done a few of these, when you have these big cavitations, you notice after you inject them, it starts seeping out, and all the colorful stuff comes out. Well, I've done it like a week later, a week later, a week later, and the patients have gotten better. So, well, I do several holes sometimes to drain it when it's large like that. But I haven't done lavage the way you're suggesting. My lavage is basically using the drainage remedies.
How do you select the trigeminal site for the injection?
Where the root canal teeth were.
Wherever there's a root canal.
Yes, all over. The worst sites. Now.
Ara, how many times might you do this procedure before you know you've saved the tooth?
A root canal tooth?
Or any.
No, the other teeth that are hot, actually, the most I've done was 6 times. The most. Usually 2-3 times, they're better. Root canal teeth, we ask the patient basically how they feel. And because these are people who don't want to lose their teeth. And I don't want to extract teeth just like because I want to extract them.
Can you comment on the difficulty in doing this procedure on the mandible versus the maxilla?
Yes.
And the different types of gingiva.
Yeah. Some tips about how to do this procedure. It's very important. Now, don't be rough and rude on the bone, especially in the mandible. Certain people have quite thick cortical plate. Now, when you put in the drill, start as you press on the rheostat, back off. Take your time, like let it cool down and go back in. If you do it quickly and you burn the bone, you create a lot of pain, and you might create a different type of cavitation there. So you have to be very gentle. You have to take your time in the posterior areas, in the mandible. You have to do it. I do it several times, back and forth, gently. I don't go the whole thing in. You have to be gentle. Like in dentistry, you have to be very gentle with those tissues because you could get smoke out of the area if you're. Well, anyhow, yes. Pardon? I do it once a week. That's it. Let me carry on with a few things because I have some really neat, interesting things for some of you who are interested in pain management. But this is basically extremely simple. The only thing what you have to worry about is what Dino mentioned, like be careful with the bone and don't inject too fast. Warn the patient. Pardon?
I had this thing broken on me about 2 or 3 times.
Well, bend the needle, it doesn't break. If you can't go back into the hole, that's another problem a lot of dentists have. What I want you to do, get the handpiece back and reorient yourself. Don't drill a new hole. Get the handpiece. Somehow the handpiece is much easier to go back in the hole. People who are nodding their heads have done it before. So don't drill another hole. Just get the handpiece, orient yourself, let your assistant help you. Okay? Don't get your eye out of the area. You have 2 assistants handing you the handpiece and the syringe right after. And bending the needle really does help. These are little hints. Okay? Yeah. Okay, we're going to skip a lot of this stuff because it's late and this is the wisdom tooth site, and now, as Dietrich told you, we have expanded. You know, you put DMPS, whatever you wish, but you're on your own. Do whatever you like.
Ara?
Yes.
Are you always injecting in the attached gingiva as suggested?
I do. It's much more comfortable. I'm a dentist. I like to keep the patient comfortable. This is an interesting case that some of you have seen. This tooth was root canal, and this patient was going berserk, had no balance, could not walk. And we've talked about it at other neural therapy C seminars. I've had a few cases like this where you have a dead tooth, you extract the tooth, you have this live nerve, and Dietrich called it a live wire going to a dead tooth. These are the cases I found that are really hurting the patients. Now you take an x-ray. The dentist at the university had done the epicoectomy. This is a university case. And this patient was labeled being crazy and nutty. And the minute I removed the tooth, she really got immediately much better. Now, I found the same situation about 3 times when patients were extremely ill and had a lot of problems if I saw this little antenna sticking on the side of the tooth.
Are they going into lateral canals, or is it just going in the tooth?
This, I don't know. It looks like bigger than a lateral canal. Look how large is that nerve. This is like comes on the side of the tooth. It's like a lateral canal. Okay, we're not going to waste any time on this because it's quite late now. We know what cavitations are. Now, I want to talk a bit of neurology because I'm really interested in pain management and how this whole bit, autonomic nervous system, central nervous system, and all that gets together. I'd like to spend about 10 minutes on this topic. You think I should do this, Dietrich? About a few years ago, I don't know, 4 or 5 years ago, I met this gentleman, Kiyoshi Maehara from Japan, at one of our pain seminars in Washington, D.C. And he gave me this paper as a present. And the topic is systemic effects of the peripheral disturbance of the trigeminal system, influence of the occlusal destruction in dogs. What these people basically did, they had 3 beagle dogs. It was well-conducted experiment, and they ground the right side of their occlusion. They reduced the vertical height by 3 millimeters. Now, immediately after they did that, of course, the teeth were sensitive. The dogs were not able to eat their food, and they started, they were affected both in their autonomic nervous system and the central nervous system. Autonomically, they lost the luster of the hair. They lost a lot of hair. They had lacrimation, and they had tremors. And centrally, the left hind legs of each dog was not powerful enough to support them, and they had a left pelvic tilt. That when the dog sat down, they could not hold themselves, so they had to sit like in that picture over there. And it's a great paper. A lot of you have copies of this. What I think these people missed is the root canal problem that happened with these 2 of the dogs. Because 2 of the dogs developed fistulas, as you see here. And they were dividing the problems between the autonomic problems and central motor problems in this experiment. Now, what I thought that they missed after I read the article several times is the effect of these dead teeth, because these dogs started developing different symptoms 6 months afterwards when the pulp tissue was dead. What I want to mention to you, when a patient arrives in your practice and you are a dentist that practices in pain management. And you're looking at the root canal teeth, the structure, the function, the biochemistry, and the psychological components. The trick is to know where to enter the system, where to start from. Are you going to start from the structural component, the autonomic component, or the biochemistry? What I find in my practice, the sharper I get after I've been practicing pain management for over 20 years, the quicker you get into the system, the faster everything resolves. This article really convinced me that the occlusal destruction and when you have autonomic disturbances with trigeminal problems, you create hell. And if anyone wants copies of this article, I think Dietrich has copies, the American Academy of Neurotherapy. And this proves to us that occlusal destruction could cause pelvic problems, musculoskeletal problems, and autonomic problems. Do you have any questions about this experiment?
Has anybody done the reverse assessment?
We have in our offices. You have. Dietrich, do you have copies of this in your? You do have, so people could get copies.
I have a copy of it, yeah, but not here with me.
I'm going to call you because I can't get it from him.
No, I have it at home, but I have half an assistant right now. Otherwise, it's me, so it's not like you're calling me and there's some assistant doing all the work. It's actually me, or you find it. Yeah, you can call me or you can call Ara.
Yes, Ed.
What happened to Ponder when he made the pronouncement about the destruction of the occlusion causing problems in females? Do you know anything about that?
Founders, yes, I know about that.
What was the story, summarily, shortly?
Well, actually, this group in Japan were students of Founder. And this Hiyoshi utilizes splints that are quite thick in height. They really open up the bite. And they follow principles quite different than the ones I follow. My principles are like the second step, like, to increase the vertical dimension. But Founder had written extensively about occlusal destruction and spinal problems, pelvic problems.
So you don't use the splints, what do you use?
It depends on the case. I use many different splints and different appliances, different injections, so it depends. Each case is different.
And the idea that the genetics, the natural can't, I'm not a dentist, so excuse my French. The dipping can't of the teeth can be genetically determined.
Yes.
In my case, mine
Yeah.
was short in the back, and I was supposed to be 6'5" instead of 5'11". That building up that space with the splint would then cause my type A behavior to disappear.
Probably, I don't know.
So, but that would be.
We use functional appliances on kids to give them the most growth potential. Functional appliances, yes. Ara, like Arana. Just skip the last name. Ara, A-R-A. Yes.
All right, and doing cavitations, if you determine that there are multiple cavitations, are you better off treating one at a time, or are you better off treating them all at the same time? Dr. Rao seems to think we should treat them all at the same time. I have thoughts about that myself.
Well, at Neurotherapy C course, I presented a paper on intraosseous neurotherapy with like cavitation sites. I would prefer to do one side at a time because you could create a huge autonomic shock. To me, I'm opening my mouth a little too wide. I think trigeminal neuralgia is a random chaos of the autonomic nervous system. What we do with neural therapy, we regulate it. Once you regulate it, in conjunction with the masticatory apparatus, because you have all these feedback loops between the autonomics and the central nervous system. As you relax the myofascial component and vertical component, at the same time, you are regulating the autonomics. That's when healing starts. So you have I skip between one to the other, and it takes a lot of knowledge and know-how how to switch from one to the other. Some patients that have cavitations, I start with myogenic splints, not hard splints. Other patients, I start with a three-way appliance, okay? Because to me, I respect the cranial people. I have an osteopath work with me. I would like to, instead of losing the patient's attention, give him a nice landing site, regulate their central nervous system with my specific splints. When I get the patients better, then I do the orthopedic orthodontic component. I like to level the playing field to relax the nervous system, okay? And then I go to the cavitations slowly, because most of the patients that come to me are, it's the last resort, basically. So we don't get easy cases. It's quite tricky. Any other questions?
So with the stabident technique, you can if you have a critical tooth that has a root canal, thinking eventually now, you can use the stabident system to nurse a tooth along that you might have a critical need
Yes,
for.
very good question. I forgot to mention, it's a great technique to convince the patient if they're feeling better after the injection. Let's say if they have an ailment, and you did that intraosseous neural therapy, and they felt better for 12 hours or 16 hours. They went home, they came back, you did it again. Then they're convinced they don't want the tooth in anymore. Thank you for the question. It's a good test for me if I want to extract the tooth or not.
You said there was an 800 number or something like that?
Yeah, I'll. Well, we'll get to it in a few minutes.
It's in the handout that you can buy for $5 with my detox.
You don't have sold out, did you?
Or I wrote it down if you want to yell it out.
Yeah, yell it out.
Okay, 1-800-263-1611. That's Valuedent.
Okay. To finish off, I'll give you one example how I do my pain work with intraosseous neurotherapy. They sent me a patient 2 years ago as a last resort, abdominal problems. I'm a dentist. So from the hospital, she can't eat any food because everything burns, okay? Nobody could treat her. They've done everything. She's on IVs. So they sent her to me. Sure enough, the molars were root canaled. She was about 70 pounds only. The first thing I did in that situation, all right, basic neural therapy, wheels on the abdominal sites. Basically, you have to take the neural therapy courses to understand what I'm doing. The people that know do it. And the second step was intraosseous neural therapy. The minute I did the intraosseous neural therapy, this woman could walk. Okay? So now to expand further on what I do, from my homotoxicology background, I use the remedies for the intraosseous sites, for the neural therapy, and for the myofascial therapy. For example, I look at the patient's constitution. One of the first questions I ask, since you're from your childhood, which organ systems is weak in you? The genital urinary tract, the lungs, and then you look at the patient's constitution. Now, the next case comes after a car accident. They have this person on IV antibiotics for months, and she still has kidney bladder problems, and they don't know why. She's a young girl. Okay, so what I do, I get the remedy of my choice, which treats that area.